Hello.
Hello.
Can you guys hear me okay?
Yes, we can.
Okay, great.
All right, awesome. While Dr. Holmes gets her slides up and gets you a little settled, I will just do a brief introduction since it is a little past 11:30. Thank you all so much for joining us today. For a few housekeeping things, if you could all stay on mute unless you have questions at the end, that would be awesome. If you have any questions during the presentation, you can absolutely shoot them in the chat, and either I will forward them along to Dr. Holmes or she will see them and answer them as she deems fit. Feel free to put your cameras on as well if you are comfortable and interested. We do appreciate a little bit of engagement during these presentations. If you're eating your lunch and don't want to be on camera, that is also totally okay. I thank Dr. Holmes so much for being here and giving us this talk on women and epilepsy today. Dr. Holmes is an adult neurologist, I believe epileptologist at Westchester Medical Center, which just recently received a Center of Excellence Award. You are now a level 4 epilepsy center, which we are so excited about. She's also on our professional advisory board and will be doing a dinner with a doctor presentation located in Poughkeepsie at Mahoney's Irish Pub on June 11th at I think 6:30 p.m. If anybody is interested, I'm happy to put the registration for that in the chat as well. Without further ado, I will pass it over to you, Dr. Holmes. Thank you again so much for being with us today.
Thanks so much for having me today. Let me just go ahead and try and share screen here. Can you guys see that? Do you see it in presentation mode or do you see the actual?
You're good.
It's good? Okay, great. So thank you. So yeah, I'll be talking about the treatment of women with epilepsy. I'm not sure exactly who all is in the audience, but like I said, we'll do questions at the end. We should have plenty of time. So, I think a lot of times when we think about women with epilepsy and critical time points, we obviously think of pregnancy. And while that is a main time point, we really like to think of it through the whole lifespan. And so, it starts with even peripuberty and when women are starting to become sexually active, when they're planning for a family. And then, of course, yes, when they're pregnant, but also postpartum and even menopause and later on in life. So, 1.3 million women of childbearing age in the US have epilepsy, and 4.3 million are women of childbearing age are prescribed anti-seizure medication. So even if they don't have epilepsy, they may be on those medications and it could relate to them in these ways. So they may be on it, for example, for headache or mood disorders. So it's really important we, take into consideration how these anti-seizure medications overall interact, as well as the effect of epilepsy itself. So we'll start with preconception. And so, preconception, about a third of women experience what's called catamenial epilepsy. And that's the worsening of their seizure frequency around menstruation. So you'll hear a lot, once a month around my period, the seizures increase, or that's when I have the flare, or that's the only time I get my seizures. And that's thought to be related to a drop in progesterone related to the menstrual cycle. And so when we figure that out, we can consider, adjusting anti-seizure medications during those times. And we ask women to kind of keep a calendar of their period, keep a calendar of their seizures, and we can kind of preemptively decide how we want to make medication adjustments around that time. And then you can also consider certain contraceptive options that help to mitigate catamenial epilepsy. So for example, progestin depot can often prevent that flare during the perimenstrual period. So when we think about what, giving me an admit that I can, when we think about what anti-seizure medication to choose, we want to kind of think about all periods through their life if we can. That way we're not like, oh, you're pregnant, now we got to change something. And we kind of want to start early and bring it up and start thinking about it, even before there are definite plans for pregnancy. And so one thing is just drug interactions. So many of the oral contraceptives that we'll talk a little bit more about will affect anti-seizure medications. And then as you're planning for pregnancy, you want to think about, if this woman is going to be considering pregnancy, anytime in the next 5 to 10 years, can we think about picking a medication that has low tetragonicity to start with first, so that if she's controlled, we don't have to try and switch medication later on. And then, for older women, but again, it's kind of a collective thing that happens throughout the lifespan of, can we prevent osteopenia and osteoporosis by avoiding inducing medications, or are they on other hormones for other reasons that might affect seizure medications and seizure control? So these medications here on the left are the ones that are very commonly what we call enzyme-inducing anti-seizure medications. So that includes phenytoin, carbamazepine, oxcarbazepine, topiramate, cenobamate, phenobarbital. And what that means is that can often interact with other medications and increase the metabolism of that drug, meaning that that drug may become less efficacious and may not work as well at that same dose. This is particularly true for oral contraceptives. And, and there was a US registry that looked at women with epilepsy, and about 79% of that cohort reported that they had had at least one unintended pregnancy. And so, we'll go through a lot more about how it is safe to go through a pregnancy, and many women will have a safe, uncomplicated pregnancy, even with epilepsy, but it's important to try and plan for it. And so, there are a couple of things that can contribute to unplanned pregnancy, and that would be difficulty with adherence to the medication, or these enzyme-inducing anti-seizure medications that reduce the efficacy of the hormonal contraception, and thereby leading to an unplanned pregnancy. On the other hand, the hormonal contraception sometimes, especially with lamotrigine, can make the anti-seizure medication less effective. So we really want to talk about using an effective method to optimize pregnancy outcomes. For many women, one thing we talk about in conjunction with OB-GYN is an IUD. And IUDs are often very effective because they don't have to worry about remembering to take it. It's very effective. It doesn't interact with any of the medications, and it can be removed when they may decide that they do want to become pregnant. On the other hand, if you're using an enzyme-inducing anti-seizure medication and they have good control, it doesn't necessarily mean they have to come off of it, but you want to counsel to use a barrier method in combination. And if they are on lamotrigine but using an oral contraceptive, we want to follow those levels very closely. And these are some of the things that, if you're not following with a neurologist or maybe even an epileptologist, often these interactions go overlooked. And so if, you are someone with epilepsy who's kind of trying to decide about contraception, you can discuss it with your OB-GYN, but you can always, reach out to an epileptologist to talk about other options as well. So folic acid is recommended for all women of childbearing age, and we recommend a supplementation of 0.4 to 1 milligram of folic acid really before conception, but also during pregnancy. So most prenatal vitamins do include folic acid, but here we're saying, start even before you're trying to get pregnant or are already pregnant. One of the reasons for that is because of this high rate of unplanned pregnancy. But the other reason is you can build up your stores over time so that when you are ready to become pregnant, you've already, established a good level of folate. There's also been some studies that have shown that specifically preconception folate supplementation reduced the risk of cognitive delay in women who had epilepsy in their children. And then there was a Norwegian population-based study of 328 children born to women with epilepsy who were on anti-seizure medications, and showed that those who were not on folic acid supplementation had 5 to 8 times higher risk of autistic traits compared to those who were on folic acid. The degree of autistic traits was also higher with lower folic acid doses and concentration. That being said, I think we usually stick to 1 milligram these days as kind of the max dose that we advise. And then we're going to talk a little bit more about congenital malformations, and unfortunately, folic acid's impact on preventing congenital malformations is more inconclusive. So really the benefit seems to be in the cognitive delay, autistic traits, and less so with the congenital malformations. So with pregnancy, we want to consider a few things. The effects of the seizures during the pregnancy, which often is the most dangerous part to the mother and the baby. The effects of anti-seizure medications during pregnancy, which are very important, but can be optimized, management throughout the pregnancy, and then the neuropsychological outcome of the child. So the risk of seizures, so we know especially with generalized tonic-clonic convulsions, the risk is very high to mother and baby. So there can be loss of oxygenation to the mom or the baby. There can be effects on the baby's heart rate. There's a higher rate of miscarriages and stillbirths. And then it has been shown that, for women who have more than 5 generalized tonic-clonic seizures during their pregnancy, there's an increased risk of developmental delay in the child. And all seizures are associated with an increased odds ratio of low birth weight, small for gestational age, and preterm delivery. We know status epilepticus accounts for 30% of maternal mortality and 50% of infant mortality. And when we look at maternal risk, the death rate during pregnancy for women with epilepsy is 10-fold higher than the general population, and that's related to SUDEP. 11.5, the odds ratio is 11.5 of death during the delivery itself for hospitalization for women with epilepsy. So we really, we see the dangers in the seizures, and we really want to try it. All of those risks are lowered by better seizure control. And so we want to use the medications to try and prevent seizures to optimize the outcome of the pregnancy for both mom and baby. So let's look at the risk of what are the risks of the medications themselves. So overall, 4 to 6% of all women on any anti-seizure medication may have major fetal malformations, and the risk is 2 to 3 times greater than the general population. However, this is particularly when there's more than one medication involved, and especially a couple specific anti-seizure medications that are included that we try to avoid when we know someone is planning for pregnancy. So there is a dose-dependent effect with valproate, and we'll talk a little bit more about valproate in a minute. And then there's some patterns that are seen, particularly with certain anti-seizure medications regarding the types of birth defects that we see. So what are major congenital malformations? What does that account for? So those are structural abnormalities with surgical, medical, or cosmetic importance. And so that can be things that affect the heart. They can be things like cleft palate, like you see in that baby there. There can be spinal bifida. And then there's a couple, things that can affect the limbs as well. And so to get a better sense of, which medications are leading to these risks, and can we get those risks for the medications to be less than the risk for the seizures themselves, there were multiple registries that were created both in North America and abroad. And the idea was to survey the outcomes of a large number of anti-seizure medication exposed pregnancies in order to provide accurate information about the magnitude of these tetratogenic risks and look for any early evidence of increased risk associated with new anti-seizure medications that come on board. So this is the North American Pregnancy Registry data, and so they were collecting data from 1997 to 2011 and looked at the percentage of major congenital malformations identified in infants exposed to specific anti-seizure medications one at a time during their first trimester, and then comparing it to infants that were not exposed to any anti-seizure medications. And so what you see is in this yellow bar here, that's, no anti-seizure medications on board, and that's about a 1% risk. And the two medications that we have the most safety data for right now are really lamotrigine and levetiracetam, and they're about 2%. So, about a 1% risk. But on the other hand, these medications on the other side here, valproic acid, phenobarbital, topiramate, we see much higher percentages, and those are the ones that we really want to try and avoid when someone is trying to get pregnant. So really, when you're looking at anatomical tetratogenesis, valproic acid has the highest risk, and that's really something we would try to get off of prior. Though there is some possible dose-dependent risk for all anti-seizure medications, and we'll talk about doses a bit more in a minute. Spinal bifida specifically, again, valproic acid has the highest rate, carbamazepine much lower. Topiramate has the oral cleft lip palate that we talked about. And then the risk of most anti-seizure medications and specific polytherapy, meaning they're on more than one medication at a time, is really still kind of uncertain because many of these registries were looking at one medication at a time. As well as the original registries didn't include some of the newer anti-seizure medications, such as lacosamide, clobazam, or veracetam. And as yet, there's been no published data on cenobamate. But this data is being collected, and we look forward to seeing what that shows. But so far, like I said, one of the points of the registry is to pick up on any early problems. And those ones that I've mentioned there has not been anything significant thus far, though the data is still being collected. So for pre-pregnancy counseling, one often question is, should the medication be adjusted before getting pregnant? And so if they're on something like valproate or phenobarbital, then absolutely we would advise trying to, before someone tries to get pregnant, to try and optimize that medication and get it off and have them controlled, ideally on one of the safer medications. If someone has been seizure-free for a prolonged period of time and the provider feels that there's low risk of recurrent seizures based on their whole picture, and often that includes MRI findings, EEG findings, then you might consider a trial of trying to come off medication before getting pregnant. And usually I tell my patients, if we're going to do that, then I want ideally to see you off medication for 3 to 6 months before you start trying to get pregnant, so that we know that you're stable off medication, as opposed to having to try and then reinitiate medication and get things under control while you're pregnant. And then the optimal therapy is one medication of those ones that we said are kind of lowest risk at the lowest possible dose that's going to control the seizures. And sometimes that takes a little bit of time to figure out. But going back to what we were saying before, if you have a new onset seizures, and you're a young woman, we may often think about starting lamotrigine or levetiracetam off the bat because we know that that has good safety data during pregnancy. And so things to remember regarding seizure frequency during pregnancy is that most women actually do maintain good seizure control throughout their pregnancy. And seizure freedom for at least 9 months prior to pregnancy is associated with a much higher rate of remaining seizure-free during the pregnancy. So if you've been seizure-free and controlled on a medication that's low risk, then you have the best chances of continuing on through your pregnancy, remaining seizure-free. And reasons for increased seizure frequency during pregnancy may be non-compliance, in that if pregnant, there's a lot going on, you forget to take your medications, or often the pharmacokinetic changes that are happening. So we'll talk a little bit more about the metabolism, but one study showed seizures significantly worsened in the second trimesters, especially as the medication levels fell to less than 65% of their preconception baseline. And then there's also sleep deprivation that contributes. So as I was saying, levetiracetam and lamotrigine kind of have the most safety data during pregnancy, and we know that pregnancy increases the body's metabolism, thereby lowering the amount of medication your body sees at the same dose. So the same dose of lamotrigine or levetiracetam prior to becoming pregnant will create a much lower level as metabolism increases throughout the pregnancy. So we have to increase the dose in order to maintain that preconception baseline. So whatever the level was where the woman was well controlled before getting pregnant, that's the level we want to make sure we maintain, and that requires increasing the dose. And this graph here kind of shows for lamotrigine, levetiracetam, and carbamazepine specifically, how much that dose had to increase between the first to third trimester to maintain a certain level. So, with lamotrigine, the study showed that the clearance during pregnancy was 350% of its baseline. So it's very important to establish that therapeutic range through drug monitoring, meaning the blood test to check your level prior to pregnancy, and then check a level as soon as someone is pregnant to say, okay, are you where you were before you got pregnant, or do we already need to start increasing your dose? And so in this WePod study, there were 24 women on lamotrigine who were followed from pre-pregnancy and then into their first trimester. And in fact, the clearance had doubled right in the first trimester. So, a common thing one of my mentors likes to tell her patients is, when you find out you're pregnant, your first call can be to your partner, the second call to your OB, and the third call to your epileptologist, so that we can stay on top of it. And so therapeutic drug monitoring does help, that's the blood work, but like I said, we're kind of always playing catch up because the clearance is constantly changing based on the metabolism as the pregnancy continues. And it's often unpredictable, and one person's metabolism is not necessarily exactly the same as the next person. So the doses need to be monitored frequently, and usually we often will do it every 2 to 4 weeks throughout the pregnancy, and then continuously adjust based on how far we are from that baseline level that we wanted. And it's not unusual for women to require even a 6-fold increase in their dosing of lamotrigine or levetiracetam throughout their pregnancy. So then postpartum, after the baby is born, we want to talk about the change now in the anti-seizure medication levels as the metabolism goes back down to where it was. There's often a lack of sleep after a baby is born, more stress, and then there's the consideration of breastfeeding. So with breastfeeding, there is much lower exposure to the medication via breast milk than there is in utero. So when they looked at milk to maternal plasma concentrations to measure the amount of anti-seizure medication in the breast milk, and those medications that are what we call lipid soluble, meaning that they kind of like to be in fat, and breast milk is very fattening, are typically in the breast milk in higher concentrations, but usually still do not produce any side effects, and is still less than when the exposure than when the baby was in utero. So levetiracetam and primidone specifically are known to exist in the breast milk at higher concentrations specific compared to other anti-seizure medications. But again, usually it doesn't produce side effects. And if it does, then it's kind of lethargy and irritability that's noticed. So one of the major studies that we have that looks at breastfeeding is the neurodevelopmental effects of anti-epileptic drugs, or the NEED study and breastfeeding that was done in the US and the UK. And they looked at cognitive outcomes of children at up to 6 years old after being born to women with epilepsy on anti-seizure medications. And 44% of those children had been breastfed. And they found that their IQs were 4 points higher in the group that was breastfed versus the group that was not, and they had higher verbal abilities. There was another study out of Norway that looked at infants that were breastfed for greater than 6 months and saw that that was associated with less impaired development at 6 months and 18 months. So the American Academy of Neurology and the American Academy of Pediatrics does advise that women with epilepsy take anti-seizure medications, breastfeed if they choose to, because there are benefits that outweigh the risk to breastfeeding. And then the other thing with the medications that we were just talking about, so often postpartum, as that metabolism comes back down, we'll have to lower the dose again. And depending on how much that dose was increased, some providers may start making cuts as soon as the baby is born, and some may do it more slowly. And then it also depends on how you're feeling. So often we'll like to provide a little extra coverage right after the baby is born, because you're more sleep deprived, stressed, and the metabolism is still slowly coming down. And then, follow those blood levels to continue to reduce it back down to the baseline dose. So then let's move on to menopause. And, for menopause, one of the things to consider is if there's any other hormones that are being supplemented and taken that, again, could impact, could lower the lamotrigine, or the anti-seizure medication could impact those hormonal doses. We also, worry about bone density, which is we see it at menopause a lot, but we want to think about it all the way through. And we know that there's radiological and histological evidence of bone disease in patients taking anti-seizure medications. And it's thought to correlate with how long they've been taking them and how many they've been taking. The most severe manifestations are osteopenia and osteoporosis, osteomalacia, all of those being basically gradations of how much bone loss there is. And the main takeaway being that that increases the risk of fractures. And so, not only can there be fractures from the seizures themselves causing a fall, but just as people get older, and if they fall, something that otherwise wouldn't have caused a fracture becomes more likely to create a fracture. The greatest risk is with inducers. So those medications that I mentioned early on that are enzyme inducers, they will increase the metabolism of vitamin D, and that low vitamin D over time can lead to osteoporosis at a younger age. So we often will supplement everyone who's on anti-seizure medications with at least over-the-counter vitamin D, and then sometimes follow levels or check DEXA scans, which are bone density scans, even from a younger age, to say, okay, they're on this inducer, how are we doing in terms of bone health? But unfortunately, it's not only the inducers, so there has been correlations between valproate and levetiracetam as well. And so, that is why we just have everyone take some calcium vitamin D over the counter while they're on anti-seizure medications often. So in conclusion, women with epilepsy should be counseled prior to conception, ideally, when considering their anti-seizure medications, what form of contraception they may want, the utilization of folic acid, why to take it, how often to take it. And most women with epilepsy have normal, healthy babies, and anti-seizure medication should ideally be optimized prior to conception with baseline levels established, and then monitored closely throughout the pregnancy, often with the blood levels being monitored and dose adjusted. That being said, we know, as I said, there is a high rate of unplanned pregnancy, and that does not mean that if you have an unplanned pregnancy that we still can't optimize the pregnancy and everything may still turn out just fine. But as much as possible, we want to try and get ahead of it. And at other stages, we can, you can talk to our epileptologist, or if you're, you have another provider that you're seeing that has concerns about breastfeeding on anti-seizure medications or hormonal therapy they're going to provide, then, seeing an epileptologist or a neurologist who's familiar with these strategies is helpful to speak to that other provider directly to talk about, what kind of options there are. So I think that's all I have, and we can do questions.
It looks like we have one in the chat from our very own TBI service coordinator. She is a 53-year-old woman who has cluster seizures during menstruation and is hospitalized. Her OB suggested Depo-provera to stop periods. What are the side effects?
Yeah, so that's kind of what I was saying before with the catamenial epilepsy. And so Depo-provera is a progesterone depot. So that can help with that clustering of seizures during menstruation. So, in terms of seizures, I think it's a good idea that could help with that increase in cluster seizures at that time. In terms of other side effects, probably discuss with gyne, but I think they're pretty low unless you want to get pregnant, and then it's not a good option.
Yes, can you hear me?
Yeah.
That was my question. I'm Kathy. I'm a TBI service coordinator here.
Yeah.
Yes, and she's not wanting to be on more drugs, but she is seeing her GYN this afternoon. So I'm hoping to convince her to try it because her epileptologist said, sure, go ahead and do that. But yeah, so with your how can I tell her that it would be safe enough to try? She's on progesterone, or should she increase her progesterone during her periods?
So the depot is more consistent, and it kind of, because it limits your periods and the seizures are happening around the time of the period, it makes it more consistent and a kind of a more likely to have a solid outcome that you're looking for. Adjusting an oral dose, I'm not sure, in terms of the progesterone, but you would adjust it to. The other alternative would be to adjust her seizure medications around that time, and so that she's still getting her period, but you're trying to adjust the seizure medications. But depending on what medications she's on, that can often be trickier, as well as produce more side effects than the depot would.
She's on several seizure medications.
Yeah, so
Currently she's on Xcopri, and she's on progesterone. She's on thyroid medication. She's on lamotrigine, levetiracetam, lorazepam, and quetiapine fumarate. So she's on quite a few. Yeah. So adjusting that is also kind of tricky with her.
Yeah, it could be. And again, I think she should discuss with her epileptologist what her options are and the risk benefits of trying to increase one of those medications. Again, if your period changes, your hormones change, then, you don't make the adjustment around those times, then it doesn't really help. Whereas the depot affects the underlying, helps to address the underlying cause, which is the hormonal changes that might be exacerbating the flares.
Yeah, I mean, she's playing, with it because she's not sure when her periods are going to stop. And, but then she's gonna have seizures like during the summer, every month during a period. So I don't know, this afternoon, she probably would like to get her hormones checked to see how far along she is with her, menopause. And I don't know, well, we'll try. I think she should try the Depo-Provera.
Yeah, and I think,
Yeah.
that's often a question that people come to see epileptologists about. So I don't know if she has an epileptologist, but you may want to tell her that if she's hesitant to do that, she should speak with an epileptologist. Particularly, there are people who specialize in women's epilepsy and are very well versed in these things. I know we have a provider now who recently joined our practice, and they can discuss, everything that they're on, what their seizures are like, and kind of discuss with her what she would like to do and what those options are.
Okay, yeah, I think I got a plan now. Thank you.
Sure.
Okay, bye.
Next then we have, what age is your recommendation for bone density test when a woman has been on anti-seizure medications for over 20 years?
Yeah, so we start early. So I think some of the recommendations are as early as if you've been on it for 5 years. So if you've been on an specifically on an inducer, if you've been on an inducer for 5 years, then it's probably enough to get a DEXA scan. For someone who's been on non-inducers for 20 years, depends which ones they're on, but it might still be worthwhile because, like I said, valproate, levetiracetam can still be linked even though they're not inducers.
Awesome. And then for another, would you like to comment on focal absence seizures in that how would those seizure types be monitored to determine seizure freedom for a time frame goal?
Yeah, so I think maybe you're referring to like the 9 months prior to pregnancy perhaps, but I think it's just a bigger question of how do we monitor for more subtle seizures where someone has impaired awareness and it may or may not be picked up. And right now, the best we can do is what they notice and what people around them notice, right? So when someone comes to an appointment, we just ask, how many do you think that you've had? But this is, especially for people who live alone, we wonder, how much is this being underestimated? But sometimes they may have other problems, like they'll say, I feel like my memory's been worse, or one time my coworker said I said XYZ and I totally don't remember having that conversation with them. Or I ended up at the store and I didn't want to go to the store. Or there are other things that make you think that, maybe they're not aware as often as they think they are. And then there can be what we call subclinical seizures, which maybe they don't manifest with anything or they're happening at night. And then that's a question of how aggressive do those need to be treated, but how do we know about them? Again, they may be complaining of things like poor sleep or poor memory, and we may check what's called an ambulatory EEG, where someone can wear it at home for 24 to 72 hours and look for unrecognized seizures and say, okay, let's just take a look. Just because it doesn't happen during those 72 hours doesn't guarantee it's never happening, but at least if they're complaining of changes that are happening on a daily basis, they just feel like their memory is off, then you have a good sense of whether that's been happening a lot and so often that you'd catch it on that ambulatory EEG.
Awesome, thank you. Is it true that women with epilepsy go through menopause earlier than most women?
So that's a good question. I don't think there's enough evidence to say that. I think there's been a few studies. One of the things that I'm excited to have happening is that there is a new consortium of epilepsy research happening regarding women with epilepsy specifically, and looking at trying to gain more information about menopause, as well as IVF and some of the other new ways that we have for hormonal treatment and pregnancy, and how do these impact women with epilepsy. or even just like egg retrieval or storage of eggs. And some of that still involves some hormones. And so we're collecting that data to analyze and get more information for everyone.
Has there been a study for women experiencing low electrolytes as a person with catamenial seizures?
Not that I'm aware of. Usually, so we know that some medications like oxcarbazepine, for example, can lower your sodium and cause hyponatremia. And that can sometimes in itself produce seizures. Usually with oxcarbazepine, it's asymptomatic, meaning that it doesn't provoke the seizures, it doesn't drop enough to do that. I don't know that particularly people with catamenial seizures have more electrolyte abnormalities, but I don't know that it's been looked at.
And another one isn't necessarily phrased as a question, is that teeth chipping on seizure medication, even with good dental hygiene.
As in, if you fall with a seizure, will you chip your tooth even if you have good dental hygiene? I'm not sure if that's the question. If that's the
It's
question.
more of like a bone density question.
Oh,
like,
a bone density question. Okay, I see.
yeah.
No, so I don't think that relates necessarily to teeth chipping, like if you don't fall and hit your teeth. Phenytoin can have gum gingival hyperplasia, but most other seizure medications should not affect your teeth. And the bone density, we're usually looking at kind of lumbar spine and hips.
Awesome. Does anybody have any follow-up questions to any of those things?
Hello, can you hear me?
Yes.
Hi. I have a daughter who has had epilepsy. She's now seizure free has been for a year, and she does experience. She's much more tense around her period, and sometimes I have her recommend, with my doctor, her doctor, take a lorazepam, and she hasn't had seizures, luckily, for a year now. Do you think that's an okay thing to do once in a while, have a lorazepam in addition to her levetiracetam?
Yeah,
I can never say it.
levetiracetam.
Yeah.
So that's one of the medication adjustments that's possible. One is to either adjust the medication that they're taking as maintenance during that perimenstrual period. The other is to add something like a benzodiazepine, and often the lorazepam, it's fine. It's a little bit shorter acting. Often we'll do clonazepam, which is slightly longer acting, and you can take 1 or 2 a day. Now there's also clobazam that's usually used more as a maintenance because lorazepam, what we call, peaks very quickly, whereas clobazam takes a long time. And so clonazepam is kind of in the middle. But yeah, it's all the same idea of trying to, the benzodiazepines fall into kind of a rescue phase. And so,
right,
you feel a little sleepier on them sometimes. You can start to build up a tolerance, but if you're only taking it for 1 week a month, that should be okay.
Yes, in fact, she only takes only when she's very stressed, very tired, and it seems so far so good.
Yeah.
Since we changed her medication from oxcarbazepine to levetiracetam, she's been doing a lot better. Like I said, seizure free so far. But I'm just another question is the long-term side effect like osteopenia? Is that the main, would you say, side effect for Capra, for levetiracetam?
Yeah, for a long-term side effect, I think that would be the only one. Most of the other side effects with levetiracetam we tend to see early on, and not necessarily because someone's been on it for a long time.
Now, what I noticed is that she's very tired often. Is that part of the medication, or?
Could be, it depends on the dose, and so how how the tiredness corresponds to the initiation of the medication and the dose. So if it's felt that it is related to the medication and not necessarily to stress or other things going on, then there are options in terms of the timing of when that dose is taken, switching to an extended release, so it's once a day, or switching the medication altogether.
Okay, well, she's working part-time, and honestly, it's probably the most she should be doing to be healthy. Another question I had is, this is very frightening what you said, that women who are on having seizures and have 10 times more chance of mortality than the regular population. That's discouraging these women to have kids at all, I would think.
Well, so the thing to remember is that's all comers. And so that may be people who either ran out of medication or didn't have their levels followed closely. And so I think that's why we really feel as epileptologists that women should be followed very closely throughout their pregnancy to make sure that they have good control and that we're staying on top of their levels.
And does that include women who have been seizure-free for a long period of time, or not?
I think that would be a very low
risk
potential of the people included in there, because most of those women do very well.
Now, some neurologists say that once they've been seizure-free for a long time, that you can decrease, eventually stop the medicine, but my daughter's neurologist says no, she's going to be on this for life. What do you think?
So it depends on what the reason is for their epilepsy. So different reasons have a different risk of having recurrent seizures. So it may depend on what sort of syndrome they think that she has, if she has MRI abnormalities, what her EEGs have shown in the past. So there are some people who have a very high success rate of coming off medication, and there are some that we know fall into a very high risk category for trying to come off.
Okay, so she does have the full-blown type, she used to have the full-blown type seizures. Maybe that's the reason.
Yeah, we'd have to know more information about it.
Okay.
Because she's had a convulsion doesn't necessarily mean why, but you know, that's something that you could discuss with your doctor, or, you know, see an epileptologist to talk about, you know, what would make her high risk or low risk for potentially coming off medication.
Now, the fact that she luckily, and I hope it continues, has been off, not having seizures for more than a year, should I still see have her see an epileptologist? Or
I think if you have questions about if the medication should be continued or discontinued, then an epileptologist is a good person to see, especially as you said, if she's young and she's thinking about getting pregnant in the future, then you might want to know, well, can she be off medication before she tries to get pregnant?
Yeah.
So it depends, you know, kind of what your question is. On the other hand, if you feel like, you know, she's doing well on the Keppra, she's not having side effects, she's happy to keep taking it, and we don't want to stop it, then maybe you don't have a question that would be helped more by seeing an epileptologist. But if you have questions regarding, is this the best medication? How long should it be continued? Then I think, you know, epileptologists are well trained in that to talk
I
about.
see. I had one more question. Let's see. Yes, my daughter is on the autism spectrum. Does that increase the chances that she would have a child that has this type of issue?
So that question is a little bit more than just epilepsies. So as far as I know, no, but you could talk to a geneticist and her neurologist about that a little bit more and see if they, again, know a reason for her autism and if they think that it would be genetic. Most of the time it's not. But yeah, it would be on a case by case basis. But we do know that people with autism are more likely to develop epilepsy than the general population.
And there's no explanation for that?
Only that we know that that means that the brain is wired a bit differently. That's what's causing the abnormal electrical activity, but why is that happening? We don't know.
Okay. What about nutrition? Do you think there's something to it to have give a special diet for kids who or people who tend to have epilepsy?
So in general, diets don't have a huge impact on their own. We often will tell people to, limit alcohol. There is evidence for the ketogenic diet and the modified Atkins diet helping with epilepsy control in conjunction with medications. And so often people who have very severe epilepsy and are having very frequent seizures who are not controlled on medications, we may also try one of those diets that can be helpful and have shown up to a 50% reduction in seizure frequency over time with medication.
And my last question is the fact that she's been seizure-free now for over a year, is that, I mean, a reason to be optimistic, or should I still be very careful? Or
it's definitely reason to be optimistic. The longer you go without seizures, your better your chances of continuing to be without seizures. And, I think our overall goal is that, unfortunately, and one of the things I didn't talk about that much, but we call the medications now anti-seizure medications. They used to be called anti-epileptic medications. And why I say that's unfortunate is because the name was changed because they're preventing seizures. They're not preventing the underlying cause. So it comes down to, what do we think for any individual, what is causing their seizures and what are their chances that they could come off medication safely, and what is the risk benefits at that point in their life. And so for some people, particularly in New York State, you have to be 1 year seizure free to drive. And so at the 1 year mark, people are like, great, I get to drive. And then they say, but can I come off medication? And so it's like, well, if you want to come off medication, then I don't want you driving because I don't know that you'll be controlled off medication. And I want to watch and see how that goes before we clear you. And a lot of times people will say, well, then never mind, I will keep taking it because it's not bothering me and I want to drive. So it, is a kind of an individual question on the risk benefits to that individual, as well as how they feel about doing it at that point in their life. But I think, 1 year is a good mark.
yeah, essentially she's back driving, and when she feels tired or stressed, then I do drive her. But she is clear to drive. So I guess we're happy about that. Well, thank you very much.
Always to get everyone back to doing everything they want to be doing, just stay controlled. And that's what I was getting at with the anti-seizure medication is, even though you're not treating the underlying cause, majority of patients, 70%, will be controlled on one of the first two medications that they try. So that means, yes, unfortunately, you have to take medication, but for majority of people, our goal is no seizures, no side effects, and we can get there. So that means you can go back to driving, go back to all the things you want to do, go back to school if you're a kid in college, do, whatever it is that you want to do, and we control it with medication.
The one thing I feel that she needs more than the average is sleep, right? When she doesn't have a good night's sleep, I'm worried, honestly. Don't you think that that's
so for sleep deprivation is kind of a mixed bag. I think most of us would agree that good sleep hygiene is beneficial and probably helps to mitigate the risk of having more seizures. That being said, not every time that you're sleep deprived are you necessarily going to have a seizure. But the way I kind of counsel patients is say, look, there are things in the environment that may be in your control, and you want to do the best you can to control those, but you're also living your life. And so there are times where something happens and we can't sleep well that night. And our goal is to have the medications there to give you that backup and increase that threshold so you don't seize. So should you go out and try and not get good sleep and be up late all the time? No, but, don't panic.
Okay.
Life happens.
Thank you very much. Yeah. Okay.
Then lastly, there is a similar concern of teratogenesis in males as pregnancy contribution, taking medications. In the realm of anti-seizure medications, what is the best data or good studies on that?
Yeah, so that's a good question. I think that's another one that's a bit up in the air. I think the evidence is very slim in terms of what medications may reduce sperm count or viability. And right now, it's not enough evidence that we specifically would or would not advise against a certain medication in males if they are trying to get pregnant. But there are some studies out there that have shown some connection with that. And then I guess in terms of good studies, that's what we're trying to figure out. Maybe we need more numbers, we need larger cohorts to kind of validate those findings.
Beautiful. Well, thank you so much. And that puts us at the end of our allotted hour. So thank you all so much for joining us. And thank you so much for Dr. Holmes's great brain and all of the information that you've shared with us today. If anybody has any additional questions, you can shoot me an email and I would be happy to reach out to Dr. Holmes to receive any additional information.
Thank you all very much.
Thank you for having me, and thank you for putting this on to the Epilepsy Foundation.
Thank you.
Thank you.